Okay, so I am thrilled to have two experts with us today who are not only experts locally, they're also experts nationally in issues related to health equity. We have Mary Travis Bassett and Sandro Galea. So I'll start by introducing Mary Bassett, Dr. Bassett. She is the director of the FXB Center for Health and Human Rights at Harvard University and the FXB Professor of Practice of Health and Human Rights in the Department of Social and Behavioral Medicine at HSPH. From 2021 to 2022, she served as health commissioner for the state of New York, and prior to that, she was also the commissioner of public health for New York City from 2014 to 2018. So thank you for being with us, Mary. And so Sandro's my boss. So Sandro is actually the chair of the Boston Board of Health, and I really appreciate him being here today. He's a physician, he's just multi-talented, epidemiologist, author, dean, and the Robert A. Knox Professor of the Boston University School of Public Health. So thank you again, thrilled to be here and looking forward to this discussion. So I want to jump right in, and I want to talk about big issues. What are the lessons that we learned in the last 3 years? Yeah.
Well, I think there were 3 lessons in the last 3 years. And, you know, COVID, as I often say in my writing and my speaking, was this tragedy that was nothing new. And let me explain what I mean by that. Because the reason COVID was a tragedy was for 3 reasons that we knew long before COVID. So number 1 was that we had underlying social and economic structures that predisposed us, and particular groups of us, to greater risk. You know, the very simple, concrete example is that people who actually worked in particular categories of job, which is, by the way, the majority of people, simply could not avoid risk the way a few others who were in sort of a knowledge economy could avoid risk. So, and that we saw, as a result, patterning of COVID sickness and COVID death really mapped directly onto our underlying social economic structures. So that's number 1. Number 2, COVID affected us as badly as it did because we were much sicker than we needed to be to begin with. We knew from February of 2020 that COVID was a disease that's going to affect much harder people who were already sick. We as a country were already much sicker, and you know, our life expectancy was 5 years behind other high-income countries. So we as a country were sort of sitting ducks because we're sicker than we need to be as COVID hit. So that's the second thing. And the third thing is, we had underinvested before COVID in exactly what could have helped us, which is broadly public health infrastructure. So underlying social economic structures, underlying poor health with health gaps, and underinvestment in public health infrastructure. And all those 3 contributed to us having the highest rate of morbidity and mortality from COVID compared to any other comparable country.
Mm-hmm. Mary, your thoughts?
Sure. So, I mean, I think that Sandro has outlined what made us so vulnerable. But we also learned some of our assets, and I think you particularly demonstrated them here. I left Massachusetts and went to New York, but before that I was on a health equity, some kind of advisory group that involved many community organizations, and I think that there was a real demonstration of the power of community partnerships, that it was so important for government to do this, and public health led it. And so that was an asset. Another asset that was displayed was the type of data that you've shown us today. I know I can speak as a former commissioner of both the state and local health department. It is really difficult to mobilize resources for surveillance. Everybody wants the data, nobody wants to pay for them. But I think that during COVID, that public health showed the importance of data. One of the things that we learned, possibly because as a nation we didn't do so well, was the importance of public communication. So you have some great communicators up here, but the ideas that you've just outlined are complicated. They're not simple. And we had to learn, I think we still have to learn, that we can trust the public to understand complicated ideas more than we know. So those are my 3 lessons. I don't usually think in bullet points, but there you go.
No, I appreciate both the positivity and the depth of your answers. I wanted to comment just on Boston, because one of the things that you said I think resonates particularly here, in that the idea of community being empowered and mobilized and actually leading the response and developing the coalitions like La Colaborativa, Equity Now and Beyond, the Black Boston COVID Coalition, they really helped us to achieve the success in terms of closing the inequities and closing the disparities. I don't think we could do that without community truly leading. So I really do appreciate that. But clearly there were weaknesses. You know, they were obvious. They were glaring. And some people have called for true structural change within public health, within our health systems, which really means sort of a dramatic shift in how these systems work. Some people have called for that. What might that look like, if you agree? What is it you want to see happen? Okay.
We're negotiating who should go first on this one. I think, I mean, there have been calls. The CDC, for example, has identified an interest in research that, that impaired its ability to act. I personally believe that it's extremely important that public health departments get the resources they need. That's the principal barrier to effectiveness. The underfunding, I mean, I don't know the Boston Public Health Commission's budget. I do know that New York State had decades of annual budget reductions with, you know, loss of like 1,000 staff. And then you have a pandemic and a public wants a response, and the resources simply were not there. So before we start redesigning the whole thing, saying, you know, research belongs in the academy, implementation belongs in health departments, let's just fund public health. I think it would be extremely short-sighted and this I feel kind of passionately about, even though I'm now in the academy, as you heard, that we retain the capacity to do sophisticated surveillance and data analysis in health departments, that we retain health labs. In public health labs across the country, there are dozens of them. So anyway, that's how I feel. Is it fragmented? Yes, extremely fragmented. But unfortunately, I think much of that was related to the political fragmentation of our country, not so much structural. Well, that's a longer conversation.
Well, a little bit. So, I mean, we're in complete agreement. You know, across the board, we spend less than $100 per person on public health in the country, which is roughly makes it about $3 billion. You know, we spend about 3% of our health dollars on public health. Now, when you think of COVID being probably about a $16 trillion cost to the economy, leaving aside the human cost, but $16 trillion, which is, by the way, about the GDP of China. That's how much impact COVID has had on the economy of this country. It's not a hard argument to make that there's a tremendous cost effectiveness to funding public health better. You know, one of the things, for example, CDC got hit hard on in the public conversation was the lab that fumbled the testing. That, you know, what nobody comments on is that lab had a sum total of 3 people working there, right? So the country was depending on a lab with 3 people there. I mean, these are egregious examples of us underfunding a system that is intended to be the sort of the wall against the $16 trillion loss. So leaving aside values, leaving aside human cost, just at a pure economic calculus, there should be tremendous more investment in public health. And I agree with Dr. Bassett that you know, it's easy to sort of toss around things like saying, well, let's restructure everything, let's rethink everything. I don't think we're actually functioning at where we could be functioning, even with our current system, even without changing anything. And we should do that as we think about restructuring.
No, absolutely. I think those are great points. Just to sort of bring this to Boston, I think one of the challenges that we've faced is just the same thing that other folks have faced around the country, that our workforce is depleted. You know, we don't have the staffing that we need to have to actually make the things happen that should happen, you know, and therefore we had to rely on external bodies, whatever, to get through elements that are key and should be sort of, you know, the things that public health is able to do and to lead. So that's, and part of that I do think is valuing public health, you know, really elevating the roles that we have. So I think that that's important from both a Boston and a national perspective. So let me ask you, and let's be realistic. Let's not be pessimistic. Let's be realistic. If you could envision being on the same stage, let's say 5 years from now, what do you think would really have changed, given all that we've gone through, which is a lot, and all the awareness that I think everybody in this room has, and you've already articulated? Will something have changed? And let's be, let's not be negative necessarily, realistic and maybe a little hopeful.
Well, maybe we'll start. I actually think things already have changed. I think we in health, we tend to have a slightly pessimistic disposition. So just to be honest about it, there are things that we talk about now that 20 years ago the public wasn't talking about. I mean, I'll use just some couple of examples. Mental health, the public conversation and awareness of the mental health challenge is now incomparable with where we were 20 years ago. I mean, presidential candidates discuss mental health problems. You have to remember, 20 years ago, this was a taboo topic in big P politics. That is a very good thing. Now, I know you can say, well, yes, but there's no funding behind it, but that's okay. That's how these things change. Like, first you change the conversation. I mean, other things, everybody in this room is conversant with the language of social determinants of health, but that wasn't the case 20 years ago. And now I'm constantly in conversation, let's say, with colleagues in the private sector who talk about social determinants of health. Again, I think you can be pessimistic about it and say, well, but is action following? But, action only follows if the conversation shifts. So I do think that things are changing. I think it is simultaneously true that things are terrible. It's simultaneously true that things should be much better. And it's also true that things are better than they were.
Well, it's hard to follow up on that. Certainly, things are much better than they were. Do I have confidence that the coffers will open and resources will flow into public health? The fact is that I don't. I mean, we're facing, all of you in public health are facing a funding cliff when the public health emergency ends, which is less than 2 weeks away now. Or maybe about 2 weeks away, on May 11th. But definitely the language of public health has changed. And I completely concur with you, Sandra, that words matter, to quote my favorite recent president. The conversation about equity, which has brought us all here today, is completely different. There is a recognition that this is not a matter of imploring individuals to behave better, which, I mean, many people still think that that's the way forward, but there also are many people who know that map, which didn't look much different when I was a student in Boston in the 70s, if you'd asked me which were the sickest neighborhoods in Boston, Mattapan, Dorchester, Roxbury would have been and we didn't even have data then. So I think that the conversation that equity has to be in everything. I was having a brief conversation with Dr. Antman, the dean of the BU School of Medicine, who said that their curriculum now has equity in everything. And that's where it has to be. This is not a tick-the-box extra thing, and increasingly we're seeing people bring an equity lens to everything. So that's important, and of course there's a willingness to talk about race and racism in a way that just didn't exist. I lived outside of the United States for many years, and when I returned, it was amazing. The word racism had disappeared. People just used this word diverse and But now the President of the United States used the phrase structural racism in his inaugural address. So we're now seeing that, and that will frame action. So I think that the challenge is going to continue to be the budget. And I think you were involved in the corporate determinants of health. We have a real conversation to have about privatization and about the growing role of the public sector, of the private sector in public life. And I'm worried that the money won't flow to government in the ways that it should. I don't think that we've overcome the sense that government fumbled, and that we, anyway, I'll stop there. I'm sure we have other questions to move to. That was not optimistic.
I was trying, but that's okay. That's okay. And going back to the data that was presented, since we said that, neither one of you is surprised, probably nobody in the audience was necessarily surprised. I think one of the things is interesting is, so we were at a 33-year difference, now a 23-year difference, kind of moving census tracts a bit. Going back to what I was saying about doing something differently, what is it that we really need to be doing? I want us to have those conversations today, because 23 years, that's egregious, in my opinion. I mean, 33, that's beyond the pale, but what do you think?
Well, I'm going to use the R word. I think that it's time for public health to start talking about reparations. Mm-hmm. We can't. You all should know that Sandro was the one who invited me to write a piece with him on this in the Lancet. I don't know how often you talk about it in public, but let me let me just say that the gaps reflect a history that is too long to be fixed with any single program. Mm-hmm. We have to do something more dramatic. Beyond that, and I think it is becoming part of a conversation that is no longer considered completely wacky. Mm-hmm. But beyond that, community coalitions, targeting place-based approaches, recognizing that individuals are not responsible for the statistics we just saw, that it's systems that are responsible, and those systems have to do more, not just equal, but that we need to have investment in systems, and by that I mean education, housing markets, labor markets, all of those that exceed the types of investments that would bring equality to these neighborhoods. More is needed. And I think that, in New York City, I was a big fan of place-based approaches. It's a very segregated city. I have to confess, I'm still learning Boston, but it looks like it's a very segregated city. And, so place-based approaches become a pathway to targeting in a way that doesn't focus on individuals and allows you to look at systems.
Yeah, so let me just, I agree with everything Dr. Bassett said. We recently published a paper, our group, where we tried to make this simple point, which is, I do not think that you can have a health equity conversation divorced from an asset equity conversation. Now, I'm using those words, they're sort of academic and clinical words, but I'm using them intentionally, because I fear that sometimes we in public health, we lose the audience by, if you very quickly sort of enter into, well, you're advocating for a communist approach, which is really, it is far from the truth. There are many steps towards asset equity that can be achieved incrementally towards a radical vision of removing health gaps. To use one concrete example from Dr. Bassett's work, for example, Dr. Bassett published, sort of, to my mind, what I think is the most convincing argument about the health benefits of raising minimum wages, right? And I think that's actually a very nice illustration of, it is not, and I'm using these words because I know they're politically charged, it is not a socialist argument, it's not a communist argument to say that everybody should have a livable wage. It is a common sense argument grounded in values, but also has real valence in health. The piece that Dr. Bassett and I wrote about reparations, we really took it from the perspective, we said right at the beginning, this is a highly charged political issue. That's not why we're writing about it. We're writing about it because actually there's no way to conceive of achieving asset equity between groups that have been disadvantaged for centuries without something like that. And that results in asset equity, which can result in health equity. So I actually think, I think what we talk about matters. I think being able to talk about things like reparations, being able to talk about things like structural racism matter. But we in health need to lead by modeling the pragmatic solutions that can then move the needle forward. And I'm taking the role of being the optimist on this panel. And I actually think we are talking about it. We are talking about these things in a way we're not. And I understand the frustration. Say, well, talking about it is not enough. That's okay. I'm not saying it's enough. All I'm simply saying is that it's a prerequisite and it's going to move us towards action.
I feel like I have to defend myself here. But let me just say that I think that the engine of change is always popular movements. And that, and we need to acknowledge that in public health and form alliances with groups that are on the move. They may not be the most conventional or, kind of middle of whatever, recognized, approved of, but that's where change comes from. So I think we should be humble in that regard and acknowledge that we can bring real evidence and data and policy analyses, but we need to align with movements to achieve change, because that's where change comes from. And I also thought of something else that I wanted to say, and now it's completely gone out of my mind. I know we only have 3 minutes left.
All right.
Maybe more. We have no minutes
Well,
left.
now you have us going. So Mary and I can go on for hours on this. So let me just add one thing about the community movements. One of my favorite sort of conceptual frames is, how do you get trust to lead to action? And I think you need 3 elements. Number 1 is competence. You actually do need technical competence. People will trust that you can move forward in action if they actually believe you can get things done. That's number 1. Number 2, you need community engagement. You can't have long-term trust that leads to action without community engagement. And number 3 is political will. You need to be able to harness the political forces and bring people from different sides of the aisle together to forge the compromise you need for particular action. Competence, community engagement, political will leads to trust, leads to action. Now, all those 3 are easy words to say, but actually hard to achieve.
Can I just add to the discussion on mistrust or trust, just because it's something that I've thought a lot about, particularly in how things happened during the COVID-19 pandemic. Those coalitions that formed, La Colaborativa, Equity Now and Beyond, Black Boston COVID Coalition, a lot of them were mobilized because they didn't trust the systems to do the work. So it was actually mistrust, in a sense, that led them to become the coalitions that they were, to empower themselves, to mobilize, and to do a lot of the work that they did. And it's actually that mistrust, as people sort of stigmatize it or say that it's something terrible, it's a source of resilience, and it's actually something that people, honestly, if you think about the Black Power movement, if you think about Black Panthers, you think about the fact that if people don't think that other people are going to do for them, they will do for themselves. And I think that that's an important thing to think about, just as we think about trust, mistrust, and those dynamics within our world. I enjoy being up here with these, senior scholars, or I'm senior too. But I think we should open this up to the audience for questions. Do we have time for a few questions?
We're out of time.
Are we out of time?
The timekeeper.
Oh, we're out of time? Oh. Let's do 2 questions. Questions from the audience? Yes.
My concern is basically about the political will. My impression is that the people who have the assets, we're talking about asset redistribution, the people who have the assets, I don't think have the political will to reduce the assets. They see it as a loss. So how do we deal with that?
I would address it from 2 ways. I think number 1 is we should never stint from making the moral argument. I think there is a moral argument that should be core to everything we do, number 1. Number 2, I think we should also get smarter about making a pragmatic argument. Let me give one example about health equity. I just wanted to sort of bring it up in our space. I think one of the challenges we talk about health equity often is that you have people with assets, I'll use the term, who are good people. They see themselves as good people, and they say, look, I care about health gaps, and I want to help, but fundamentally, in my heart, I think it's not really my problem, because I'm going to be fine. We need to get better, for example, at showing data like this. Maternal mortality, which is one of the blights on this country's conscience, which, our maternal mortality as a country is about 3 times higher than it is other comparable countries. But when you do analysis and you restrict maternal mortality to the richest 1% of counties, maternal mortality still remains twice as high as all other countries, right? So the argument needs to be made that health gaps hold us all back. My favorite preacher on the importance of narrowing gaps is none other than the poster child for capitalism, Jamie Dimon, who is the CEO of Chase. In his stockholders' quarterly report, he's written explicitly about the dangers of too much inequality. Now, he's not taking it from a values point of view, although he does that for the brochure. He's saying that fundamentally, too much inequality hurts everybody, people on both sides of the ledger. I think we need to get better at making that argument.
Well, I think we ought to stress for the audience here today that all of the data suggests that this country as a whole is in real trouble. Everybody. Our life expectancy has been declining since 2017. It took a real hit during COVID, but it was going down before that. And this was in all groups. So, as Sandro is saying, it's not good for anybody when an entire country becomes unstable. So that's the rationale for, people who have more parting with a little bit. Because they want to maintain stability. And it's just when things get too unequal, it's simply not stable. And we've seen levels of inequality that haven't been seen in going on a century in this country. We're sort of in this Gilded Age now. This is not a stable arrangement. So I guess I don't know what Jamie Dimon means. I don't think he's thinking about reparations. But he's right that it is not stable, and the state has been the engine of redistribution. And it's the state that has been under attack. And that's part of why public health has so much trouble. It came to me what I wanted to say, and then this, maybe, Sandra, we can find some area where we don't completely agree, is that I think public health is always in its best place when it makes the argument based on lives saved. Not on the basis of cost effectiveness, but not saying that we're a good investment, saying that, that we are good for the economy. I think we do better when we talk about our role in preserving and extending life, healthy life. So that was what I wanted to add earlier when it skipped my mind. And last word to you, Bisola.
We actually want to take one more question, if you guys don't mind. There's one question in the back. I think we may need a microphone. Can somebody?
Thanks. Nancy Krieger, Harvard T.H. Chan School of Public Health. I really want to thank many issues that you're raising, and I really appreciate the many points that you've come up. And I also think that public health needs to be a bit more bold. When we talk about the need for money, right now, you look at, for example, CDC talking what it needs for the data modernization plan. It said, oh my God, it's so much money, something 10 billion a year, whatever. It's 1% of the US military budget. And when you look at the number of people who died, back to your point, Mary, of how, looking at lives saved, the number of people that died in COVID, it's more than what we've had in US casualties since World War II in terms of military. And so I think framing what needs to happen around taxes as a fundamental source of revenue, and then also that the people that are detracting from the state doing things are actually in state government now. That the whole idea of having the emphasis to have a state that is not a public health nanny state is what's core to a lot of conservative positions now that really need to be defended, so that when we say the state, having a more nuanced view of understanding that there are those from inside the state right now that are trying to basically stop it from having public health regulations, stop it from actually having redistribution of income. So I think we in public health need to be able to talk about this. We need to be able to talk really about the political economy of health, talk about what's been happening with gerrymandering, allowing state legislatures to go absolutely awry, whether it's at congressional level or within state legislatures themselves, and that these need to be part of what public health is pointing to, so that these discussions I find around equity are often leaving out actually these very crucial political elements that are strangling what needs to happen in public health. And the last point related to that is that I actually think that, with the discussion that is happening increasingly in the US, not only around racism, but racial capitalism, that actually we need to have real discussions about our political economy and from the standpoint of who the different allies are that have really pushed forward the discussions. There's a good history of what socialists have done in this country that I think shouldn't be undermined.
We appreciate that. one more question? Okay, we'll take one more question from the audience or comment. Anyone? Okay.
Hi, everyone. My name is Darren Lita. I use she, her, ella pronouns, and I'm the Senior Manager of Substance Use at Mass League of Community Health Center. Currently, I'm working on a grant right now for substance use services and how to make it more equitable for Black, Latina, and Native populations, since we suffer most with on overdose rates. And back to your community point, and this is something that I scream to the rooftops every meeting I go to, is that there's always less community people in these rooms and more people with letters behind their names. And so just going back to whoever was talking before, because I couldn't see you, like, how do we change that, and how do we not, and 'cause unfortunately, and I always say it, I am very proud of where I come from and the thoughts and comments that I say. I think it's hypocritical of us to continue to have these conversations when community are not mostly in the rooms, and it's just folks that might have higher education, because as my congresswoman says, the people that are closest to the pain are the solutions. We have the best solutions. And so how do you react to that? And of course, as everyone's doing their work to make sure that community is always centered, not just community, but grassroots, and folks that have been doing this work for a long time. And that's what I'm working on.
I really appreciate that comment, and I think we're actually going to end on that point, because I think that's a really powerful point that you're making. We will have a panel that will have more community leaders on it, and we invited, community to these spaces. Oftentimes, these are not events that are at the right time. They're not offering the true opportunity, and the door isn't truly open at these spaces, which I think is important for us to understand. I also want to just say that, for me, a lot of what we're talking about, and I think it's a really important, rich conversation, but we talk about this idea of community partnerships and community engagement, and what does that really mean? We try to say that's like sharing resources, that's like maybe we're working together, and I appreciate it tends to be in some ways jargon that we're throwing around. What I think is that what we're talking about is that communities should be leading these efforts. Communities should be in front, and they should be the people who are actually helping to determine some of what's happening here. In fact, most of what's happening here, honestly. I would also say just final comment before we end, because I think this is a really rich panel. I think we really started the day off in a powerful way. Public health, we need to have more political influence. I appreciate that piece. We need to be more bold. We need to be more visionary. And I'd like us here in this space today to think along those lines. Let's do things a bit differently. We don't have to have complete structural change, but we do need to do some things differently. So let's end there. Thank you so much, Mary. Thank you so much, Sandro. I really appreciate this opportunity. Thank you.